Hi, my name is Dr. Charles Simone. I'm a thoracic radiation oncologist at the New York Proton Center and Memorial Sloan Kettering Cancer Center, and I'm the principal investigator of NRG-LU008. NRG-LU008 is looking at patients with locally advanced non-small cell lung cancer, where we're essentially replacing standard of care chemoradiation to the primary tumor and instead delivering stereotactic body radiation therapy to the primary tumor. The trial is a phase 3 randomized trial, so patients in the control arm are receiving standard of care chemoradiation to both the primary tumor as well as the mediastinum, followed by immunotherapy afterwards. Patients in the experimental arm are getting SBRT to the primary tumor only without conventional fractionation. Immediately following the stereotactic treatment to the primary tumor, patients receive chemoradiation to the mediastinum, followed by immunotherapy. I anticipate that the most common questions we'll receive from the study are going to be around eligibility. First, I think investigators are going to be a little surprised that the trial is so pragmatic relative to other trials in our group. Patients can have ECOG performance status from 0 to 2. We've done away with most of the time restrictions around diagnosis and testing and imaging requirements. Patients can have other malignancies as well. So we really made the trial very pragmatic. The one other eligibility question I think patients will ask is, while we do allow patients with tumors relatively large, up to 7 centimeters, and both central and peripherally located, the one patient population we've excluded is patients with very centrally located tumors within 2 centimeters of central mediastinal lymph nodes. I think the one thing I would like sites to know about the study is how exciting it is that we really have an opportunity to both potentially improve outcomes as well as reduce toxicities with this regimen. By delivering a higher biological effective dose to the primary tumor, the stereotactic body radiation therapy should improve local tumor control. We know that's really important for patients with locally advanced non-small cell lung cancer, since the site of non-metastatic failure is most common in the primary tumor itself, and primary tumor failure drives future brain metastasis and also drives down overall survival. So by treating to a higher biological effective dose to the primary tumor, we should improve local control and therefore improve overall survival. But by delivering stereotactic radiation and being very tight with our margins, we should also reduce lung toxicity, which we've seen in our phase 2 studies as well. So it's a real way to better preserve quality of life, reduce toxicity, and improve tumor control in these patients.